Dear Bob, it's an absolute pleasure to welcome you to the International ORP Executive Interview Series 2025. The series highlights global leaders in occupational health and safety, and this year is particularly special as we celebrate 25 years of the International ORP Foundation in Cartagena de Indias, Colombia. We are so excited to have you with us today.
Thank you so much for having me. It's a pleasure to be here and an honor to be asked to do this interview.
Thank you so much. So, before we start, let me take a brief moment to introduce you to our audience. Dr. Cohen is a leading expert in occupational lung diseases. He is a professor of medicine and director of occupational lung disease program with more than 30 years of experience in clinical pulmonary medicine and workplace health. Dr. Cohen has dedicated his career to researching and treating respiratory illnesses caused by workplace exposures, helping to improve early detection and prevention of occupational lung diseases. Does everything sound correct?
Sounds great. Thank you.
Great. So let's give our audience a quick roadmap of what's ahead. So we will start by exploring recent advancements in managing respiratory illnesses. Then we will talk tech and see applications of artificial intelligence in lung diseases. Next, we will dive into workplace protection. And finally, we will wrap up by discussing the role of collaboration. Dr. Cohen, are we ready to start?
Yes, I am. Thank you.
Great. So, Bob Cohen, you have spent decades researching respiratory illnesses. What recent advancements are making the biggest differences in managing lung diseases like pneumoconiosis and silicosis in high-risk industries?
I think the most important thing has been primary and secondary prevention. And by primary prevention, I mean a real important focus on controlling dust in the workplaces, using new technologies and old technologies combined to really control all components of dust that we can find in the workplace. And recently been focused very much on respirable crystalline silica, which even though it's an ancient exposure, is still causing a large amount of disease throughout the world. The second thing has been an important focus on medical surveillance and early detection of disease in the working populations. And so we've been using old technologies such as plain chest radiography, but having digital technology allows experts from different places nationally and internationally to review images and centrally collect and analyze data to detect the earliest signs of disease on plain chest radiography. And we've also had improved use of computerized tomography, three-dimensional imaging of the chest for early signs of pneumoconiosis. And I think that that's been and will be a very important move in the future to make this technology, which was previously only diagnostic, into a much more surveillance technology as radiation doses and costs for that technology decline, and we can now use it to survey populations. So those are two of the important things. And I think the third thing is the improving the role of physiologic testing of exposed populations to detect early disease. We've spent so many years looking mainly at spirometry, which only looks at the bellows function of the lungs, but there's been improved and increased emphasis on looking at the lung diffusing capacity, which looks at the gas exchange surface of the lungs and can detect early emphysema, which is certainly can be caused by occupational exposures, and early scarring of the lungs, early interstitial lung disease. So my hope is that going forward, we'll have these technologies of computerized tomography and lung diffusing capacity to survey populations, not just for diagnosis when people are already symptomatic from their disease.
Thank you for sharing such a fascinating advancements. And if I could ask, how can we ensure these technologies are accessible to workers globally?
Well, the technology has improved in that they are cheaper and the side effects, particularly of computerized tomography, are much less as the radiation doses improve. In the United States, we've been able to leverage campaigns for early detection of lung cancer in populations to expand that to working populations, for example, that are exposed to asbestos, and making sure that they receive that technology. But I think it's really important that we advocate as healthcare providers in occupational medicine and occupational diseases to advocate that our regulatory agencies include these technologies in the mandatory regulatory surveillance of exposed workers. So I think working together with stakeholders in industry, stakeholders in labor unions, and in the medical community, we can advance and push forward for these technologies to become used in a mass way. And then it can become available to countries that aren't as resourced because they will become cheaper and more portable.
Such an insightful perspective. It's absolutely encouraging to hear about the progress. So, since we have discussed advancements in managing lung diseases, let's take a deeper look at the role of technology. Artificial intelligence and advanced imaging techniques are revolutionizing how we detect and treat occupational lung conditions. Dr. Cohen, are there any artificial intelligence driven tools or innovations in medical imaging that you consider game changers?
I think so. What we've been relying upon for decades has been the subjective interpretation and classification of chest images to find the earliest signs of occupational lung disease, those early signs of pneumoconiosis and or emphysema, or other signs of obstructive lung diseases. But that's a very subjective process. It's a very time-consuming process. And it also requires, at least in the United States, and I believe in Australia and some other countries, to have at least two people review these images to make sure that we are not missing anything, that we have at least two sets of eyes on these images so that we can detect the earliest signs of disease. But that's really, again, a very subjective process. Given that we are now introducing more and more computerized three-dimensional imaging of the chest, that is a perfect platform to introduce artificial intelligence classifications or interpretations of these images. It's more difficult with plain chest radiography because you're superimposing bones and soft tissues over each other, and the detection of those small opacities can be very, very difficult given changes in penetration or X-ray energy used in these images, and the quality of the images can vary, making it very difficult to apply artificial intelligence, although there are some attempts at it. But I think as computerized tomography, low dose screening, CT scanning becomes much more prevalent, that's perfect for artificial intelligence. We can take out subjectivity, we can take out bias. We've reported in this country and others, depending on who is reading the X-rays and for what purpose, the classifier may be biased, and that will affect the classification of those images. AI, I think, will remove that, and we can have a much more a standardized, non-subjective, objective classification of images detecting early disease in a very quick way that won't take long periods of time requiring more than one reader. And then I think we can refer those workers for further evaluation. We can send them back to work, hopefully with lower exposures, or remove them from exposure depending on the severity of their disease. So I am really hopeful that AI will help us in the classification of advanced chest imaging going forward.
Thank you so much for sharing your thoughts. Technology is moving so fast. And building up on this, how do we balance, and whether we should balance, artificial intelligence with traditional medical expertise in diagnosing occupational lung diseases?
Well, clearly, when we have a classification that would, say, be performed by AI, or even as it is done now, it's done by classifiers who have no knowledge or shouldn't have knowledge of the history of the worker's exposure. They should be unbiased as they classify these images. And if they return a positive finding of an image of pneumoconiosis or opacities that are consistent with pneumoconiosis, it's really up to the traditional occupational medicine physicians, occupational respiratory specialists, and other physicians to put that in the context of the workplace exposures, the workplace exposure control technologies and personal protective equipment to make a decision as to what those findings on the chest imaging mean. Is it related to that workplace? Is it related to something else? And putting that all in context. And at this point, that really still requires human intervention. I'm sure there'll be algorithms that may be developed in the future, but I think that combination of the artificial intelligence initial classifications combined with then the contextual analysis of an occupational medicine specialist is what is still going to be needed going forward.
For sure, could not agree more. And as we move on, let's take a look at how we can better protect every worker. Despite increased awareness, many workers are still exposed to hazardous dust, leading to long-term health consequences. Therefore, Doctor, what do you see as the biggest challenges in protecting workers from hazardous dust exposure?
I think that we have to be extremely vigilant about doing workplace sampling, workplace environmental controls to do the primary prevention that's necessary. So the workplaces that clearly have in their atmosphere dusts and mineral dusts or other dusts or respiratory toxicants and hazards, that we have to be monitoring those very, very carefully in the workplace. And that has to be followed up by the regulatory agencies of the countries that are involved. We can't take our eyes off of that. And we have to make sure that we are implementing these workplace exposure controls, not just when inspectors are there, but every single day. And then the backup to that is the medical surveillance to see if there is disease, because no matter what your sampling and dust levels show, if you have workers that are coming from that workplace with disease, something is wrong. And so the secondary prevention, the medical surveillance, really isn't just to identify workers with early disease to help them, but it's also to identify a sick workplace. We want to see where the primary workplace exposure controls are failing. And so that feedback loop is incredibly important, that we really pay close attention to it. And I think the new technologies that we spoke about a bit earlier are going to help us because we'll be able to objectively identify early disease either through the imaging or through advanced, more appropriate physiologic testing, and then be able to take care of those workers, but also go back and look at that workplace. So it's really an important collaboration between industry, between regulatory agencies in each country, and between the workers' advocates to all work together to make sure that all components of primary and secondary prevention are in place. And I should mention tertiary prevention or care of people that are already ill. I think it's really important that even if the first two levels of prevention fail and we have sick workers, we must take good care of them. We must provide adequate rehabilitation, compensation for those workers that are affected. And I think that at all three tiers, we have to be very, very vigilant and apply a lot of effort.
Such a powerful takeaway. And based on what we have just discussed, what are the most common obstacles to effective dust control in workplaces?
I think if we have workplaces that are very small, that don't have good capital investment, that have a workforce that's vulnerable, perhaps not organized workforce, then we can see conditions that are ripe for high exposures and for disease to develop. I would say the clearest example of that internationally has been the epidemic of silicosis in workers that fabricate artificial stone countertops. In Spain and Australia, the United States and Italy and other countries, the workers that are affected by this tend to be immigrant workers or workers that have fewer protections. And I think that we have to make sure that the big workplaces that have lots of investment and a lot of attention, they probably will do better. But these small workplaces, we have to really pay very, very close attention and making sure that we're not failing that workforce in that sector.
That is a great point. Thank you so much.
My pleasure.
And to tie this all together, it's clear that tackling occupational lung diseases requires a global effort. Doctor, this year we're proud to celebrate 25 years of the International ORP Foundation in Cartagena de Indias, Colombia. How do you think gatherings like these contribute to advancing global occupational health and safety practices?
I must say that I've learned over the years that international collaboration is incredibly powerful. We have learned so much from our colleagues in Latin America, our colleagues in Australia, and throughout in Europe and throughout the world. And we can amplify each other's efforts. We can help each other. And I think that that's been such an important and such a powerful thing. One nation and one group of workers and health providers in a single country is really nowhere near as powerful as drawing on that international experience. So I applaud ORP, and I'm looking forward to you having a wonderful and successful conference in Cartagena, and I think it's incredibly important.
Thank you so much for these kind words. And how can we ensure the momentum from such events continues afterward?
Well, I think that the networks that we develop in these international meetings must continue. We have the wonderful advantage of virtual meetings nowadays that are commonplace and excellent. And I think ongoing meetings virtually and ongoing workshops, ongoing efforts to help improve our regulations and our medicine and our science is the way to move forward. We can't just have a meeting and enjoy each other's company for a short time and then forget about it. So I think that continuing to have educational activities and these conferences and networks on a regular basis is the way to move forward.
That is so true. Thank you so much.
My pleasure.
Thank you. And before we close, do you have any final thoughts or words of advice to our audience?
No, but I encourage them to become active and to participate not only in their national medical societies and national advocacy movements, but in the international organizations such as ORP. So I salute you and looking forward to working closely with you in the future.
That sounds so nice. Thank you so much, and thanks
Thank
to our
you.
audience for joining us today.
It was my pleasure. Have a wonderful day.
Thank you.
Bye-bye.
Bye-bye.